Thank you, Chairman. I'll be talking on distal versus proximal protection in carotid stenting. And the cause of strokes during carotid stenting is mostly atheroembolic due to the Cheese-Sprader effect, periprocedural embolism due to access, filter navigation, movement, aortic arch disease, severe hypertension, which may happen due to carotid body stimulation, atrial fibrillation, and air embolism. And that's a concern during carotid stenting. So we first know that the role of protection devices is getting more and more prominent and important, and almost being a mandate now to use protection devices during carotid stenting. The issue is that protection devices are not perfect, and we have a lot of them, and the embolic protection devices, currently there's no level 1 support. The current recommendations during carotid stenting is at best a class 2A indication with a level of evidence C. The randomized studies impacting EPD on clinical outcomes have not been great. There are multiple comparative retrospective analysis, and especially for recently symptomatic plaques, there's even less data. Now, for the high-risk patients, there is remarkable data recently with various systems, which could be proximal or distal protection. But again, the use of embolic protection devices have been so diverse, starting from the EVA-3S for only 20% of patients to the CREST study, where 95% of patients use protection devices. So in general, if you divide cerebral protection devices, you have the distal occlusion, which is basically commonly what we use in this country is the Percocet. You have distal filters, which are multiple, the Emboshield, the filter wire, the AngioGuard, the Spider, and the AccuNet. The FiberNet is here, and the proximal occlusion devices, of which the MoMA is the most popular. So how do we use these devices, and how do they act? They act by, a filter acts just by protecting the stuff from going down into the distal carotids by acting as a sheath. The distal flow blockage devices like the Percocet acts by balloon occlusion. And then you have the flow reversal device like the GAW and the MoMA devices, which proximally and distally flow block the common carotid and the external carotid artery. The filter wire is basically a sort of a suspended radioluminol loop, like a butterfly net, and you can see that's how it looks like. The Spider is very similar, but the advantage is you can use another wire and then cross over onto the filter after that. It's 6 French compatible. The Emboshield, a little different design, but again, the advantage is bare wire access is possible and it's more visible. The AccuNet, again, is flexible, can go to difficult anatomy, and it has a high flexible filter basket, and I'll tell you what the advantages of that. And the GORE has only 100 micron pores, so it is more effective in blocking distal embolization. It has a hydrophilic heparin coating. So many of these filter devices in general have various pluses and negatives, which we should know in the cath lab when you start using these devices. There's also the AngioGuard embolic capture guide wire system, which again has a better transition system, which is very important if you don't want to distally embolize during the passage of the filters. And then you have this new system, which is a different design completely, which is a FiberNet, which basically is just like a net and is very low profile, and the particles entrap as small as 40 microns in the FiberNet and really can help in distal. So there's various profiles, but we have to understand they're very, very low profile, and the embolic protection devices, which are distal, are more low profile, and the sheets are lower in those devices, and the sheets are larger in the proximal protection devices. That's what we need to know. So when you're starting a procedure, we should know which French catheters to start with the groin. Otherwise, you would end up with not being able to navigate these things properly. Now, just to tell you that the EPD crossing profile of the FiberNet is extremely low. It's 1.75 to 7 millimeter vessel size, and the crossing profile is up to 1.75 in the low diameter FiberNet. So clearly, it's a very low profile device, and we would like to see it more. The other important thing is the landing zone. You need to know with these filters how much of landing zone you have, and some idea should be known. And remember, again, the FiberNet has a very low landing zone. Again, the transition zones, as I said, some are very smooth, some are not so smooth. That could impact the distal embolization. Again, the pattern of the pore will decide how much it's going to protect. So, for example, it could vary from 100 microns to 140 microns, and clearly we should know which of these filters you're doing, but clearly the pore size has not impacted the major stroke rate at 30 days with whichever embolic protection device you used. So distal protection devices of filter forms, advantages, they preserve antegrade flow. You can use a contrast. You can quickly do these procedures. They avoid external carotid cannulation. They're easy to flex and move. The disadvantages, obviously, they do not capture all debris. The filters may clog, cause spasm, and the embolization could happen even before the filter deployment. The retrieval sheath, if you are not careful, you could snag this filter on that or snag the protection device itself on the stent, and it's very difficult sometimes to pass them on tortuous distal internal carotid arteries. And tandem lesions, you may risk more embolization. Now, simple steps for interventions in radiologists using these devices. Never advance a filter without target ACT of greater than 250. Hold the wire steady. Don't let the filter move. So if the filter keeps moving as you're doing the dipler, you get spasm and dissection. Keep an eye on the filter all the time. And when a buddy wire is used, make sure the wire you're removing is the buddy wire and not the filter wire before you stent, or you'll strap the filter onto the stent. So these are very simple things that we should always keep a watch on. Look for spasm. When the filter slow flow occurs, it may be because of muck going down into the filter. And keep the two levers wide open during filter removal so that all the muck comes backwards and there's back bleeding from the guide factor sheath. Remember to watch for wire kink, filter jamming, and filter detachment. These are simple things which you should watch for. This is a nasty right internal carotid angiogram, carotid stenting done with the EP filter. You can see that on the top there. And you have a standard procedure being done with a carotid well stent. And this is the final angiogram which is showing a good result. You can do bilateral similarly. We have some data with bilateral which I will share with you. This is the one on the left internal carotid with the carotid wall. You finish that. And sometimes you may have to go, though it's a very small group, to do it at the same time with a protection device, use the same filters on both sides. The advantage really in our scenario is the cost of using a new filter immediately on both sides. But you've got to be careful in bilateral carotid stenting. Again, you can get a nice result in these cases. So some of the disasters are filter detachment, and that is usually operator dependent, and it's because of forcibly pulling on the filter wire. And always keep your eye on the guide sheath and the landing zone. Now, when you get a slow flow or occlusion of the filter, the treatment depends on whether there's a filling defect or there's no filling defect. If there's a no filling defect, close the filter and remove it. If there's a filling defect, aspirate with an export and then close the filter and remove it. Now, the distal occlusion devices are like the PercuSurge, and this is simply a very nasty carotid where you need to have really good protection, and this is where you use a PercuSurge there, and you put a long stent 8 into 36 carotid roll and use a post-dilatation and get a good result. So large plaque burdens is where I like to protect it so that it doesn't go down, and that is the important problem with the balloon occlusion devices is there's no antegrade flow, and many of the patients are intolerant to that, and balloon-induced injury is important to understand, and we should be very careful that embolism does not occur through collaterals. But it's easy to use and easy to cross. But ultimately, there are certain areas where you simply cannot use distal protection devices. Look at this curve, lesion, bends in internal carotid, and that's when you look for the proximal embolic protection devices. And the concept is that you dilate balloons in the external carotid and the common carotid, put the stent, and then aspirate and remove all the stuff so that you don't get all the stuff going up the internal carotid artery. So there are two types: the Gore flow reversal system, which uses, there's no blood loss because you're putting back the blood into the venous system. I'm not going to go through that, but MoMA is the most popular, where you have two proximal and a distal external carotid artery balloon, and you aspirate it after the stenting so that you remove all the blood. The key fact with the MoMA is that you need two anchoring balloons. you should cross it under protection. You could get about a 3% MACE events with the proximal MOMA device. And similarly with the EMPIRE trial, very low event rates of about 3% in symptomatic patients and octogenarians. So this is the first randomized study of proximal versus distal protection, and this is of the MOMA versus the filter, and clearly showed that we had lower events in the MOMA group than the filter group. And also it's important that we assess the transcranial Doppler data, which sometimes is more relevant when we do a distal protection. There is a lot of data which shows that you have a lot of MR signals which show an increased microembolization despite using good protection devices like the filters. So clearly the MES counts are lower with the MOMA than the filter group, and though the hospital events were no significant. So to conclude, I would say that before I conclude, I just show our data with Madras Medical Mission. We have 62 patients of unilateral carotid stenting. This is published in the Indian Heart Journal. And we've used in those 62 patients, 42 patients with the embolic protection devices, which are distal, EP filters in 36 and embo shields in 6, with very low complications rates, 4 TIAs and 1 minor stroke only in those group. And bilateral, we have 13 patients with 26 procedures, in which all of them had embolic protection, and 22 had filters, 2 with Percusurge and 2 with AngioGuard. And again, staging, this was a question asked. Many of them will have simultaneous, some at 24 hours and some at 24 or more than hours. So in conclusion, ladies and gentlemen, I would say that embolic events complicate atherosclerotic intervention, and the evidence to use EPDs in carotid stenting, ideal EPD is not available. You should have knowledge about all these. Distal protection, especially filters, are used commonly, but beware, it has limitations and it does not protect everything. And most important, I think that proximal protection devices may be useful in complex lesions because of its superiority. Thank you very much.
We'll take a couple of questions on Dr. Ajit's talk, and there was one pending comment on Dr. Yadav's discussion on CA versus endo treatment. Dr. Collins. Would you like to make your comment, sir? A mic for him?
I think that was a very interesting presentation, and I agree with the summary. I think carotid stenting and carotid endarterectomy is probably one of the most political topics in medical, probably almost in medical history. And when we talk about the results of the CREST trial, I think it's important to put it in perspective. This was a randomized trial. This trial took over 10 years to perform, and the results are what the results are. So the hard endpoints that the FDA made the operators or made the investigators use included MI. So I think to throw MI out after that was one of the designated endpoints mandated by the FDA is not a very smart or very honest thing to do. I will tell you that there's a move now to go with the CREST-2 trial, and that's because of all the controversy after CREST-1. And I'll also tell you that the design of that trial will include an arm that is looking at best medical therapy, but I'd also tell you that the hard endpoint that was mandated by the FDA in the first trial, MI, is going to be removed from that trial. And so I would ask you, even though it's probably 10 years from the end of that trial being reported, what the results are going to be. It's, one of the things that I mentioned yesterday in my talk is that the design of the trial very much dictates what the results are going to be. So, not to be clairvoyant, but I can tell you that if you take MI out, then the results are going to favor surgical therapy. And the question will be whether or not the medical therapy arm, trumps everything as far as asymptomatic patients or not.
In relation to your presentation, the flow reversal devices work well, but they're not without their complications. We've had one where we couldn't get the balloon in the external carotid artery to deflate, so we couldn't withdraw the device, and actually had to go in and puncture it, aspirate it, and then take the device down. So they're not without their complications in themselves. And I think your summary was very good, where what you choose to use is really what you're most facile with when you're doing the procedure.
Thank you.
Okay, thank you, Mr. Chairman.